So it really comes down to what the patient tells us. If they have perfect seizure control and they are having terrible cognitive impairments, and we look at their EEG and they're having a lot of spikes like all the time, that's a case where I would be like, I don't know, should we maybe adjust the medicines? Even though they're not having seizures, would it help?
Fellow Homo sapiens, welcome back to Epilepsy Sparks Insights. Lots of people with an epilepsy can tell you that memory issues are one of their biggest challenges. Cognitive deficits, whether they be permanent or transient, can actually be disabling for learning, employment, relationships, confidence, and overall quality of life. So I am delighted to introduce to you the multi-award-winning neurologist, epileptologist, and neuroscientist, PI of the Kleen Lab, Jon Kleen from UCSF US. Please don't forget to like, comment, and subscribe to our channel so that we can spread awareness and understanding of the epilepsies around the world.
I do a bunch of different things, but kind of two main domains. One is the clinician, so I see patients with epilepsy in both the clinic, so the outpatient side, and then also the inpatient side. We have an epilepsy monitoring unit, and we also read the EEG for anyone who's got an EEG on in the entire hospital, ICUs, et cetera. So that is my clinical realm. And then I have a lab as well where I study a couple of main things, but mainly cognition, particularly cognition in epilepsy, or how epilepsy affects memory, cognition in general. And then also just studying basically seizures, intracranial seizure activity, meaning from sensors actually implanted inside the brain, to try to understand if we can basically make better ways to detect where seizures come from and how they spread, and hopefully cure them with surgery, or at least reduce them with stimulators.
Cure's a dodgy word, isn't it? It's like, ideally, but we have to be careful, I think, with the term.
Yeah, absolutely. There's really, when we say cure, it's at least stopping seizures is kind of like, is that a cure? But at least that's as close as we can get for like stopping something like epilepsy. So we can do it with resection surgery, and happy to talk about that more. But really, all of our other methods are basically reducing seizures, which are, the essence of epilepsy. And if we can just at least get rid of those for patients, that can be life-changing.
Yeah, but it is, and certainly can be. But going on the cognition side, and mental health is another thing that's all part of epilepsy, in my opinion. But what led you to focus on the cognition side? Because I haven't spoken to anybody who's gone, that's my thing before.
Yeah, well, I don't want to go too far back, but basically, like back in college, I was in like a psychology class, and they were talking about the psychological domains. I picked up a textbook, and I saw this section about the hippocampus, which is a structure deep in the brain, important for memory. And I was reading about the research that they were doing in memory, and I was like just really amazed that you could understand how like the brain circuits actually worked. I always thought the brain is just so complicated. But then I just got really pumped about it and got into research in college, and started studying that more and more. And then went to grad school or MD, PhD, and a lab that was working on memory was also working on epilepsy. And I thought the two combined was like pretty interesting, especially as a direct clinical translation to it. But then I didn't understand how intertwined they were at the time. Actually, there's, memory, epilepsy, and cognitive impairments kind of go hand in hand a lot. And there was just so much work to be done. So it really got me very pumped, very motivated to continue this work.
And it was for this work on what you've achieved so far that you got a couple of awards, I believe, correct?
Yes, the Dreyfus Penry AAN Award last year, and then the Emerging Scholar Award from the ANA, so the American Neurological Association. Yeah, I definitely got lucky there. Also, Young Investigator Award a few years before that from the AES, but really just a lot of support from these organizations for this sort of, they and a lot of other people know that this is a very important problem, cognition, epilepsy, and it's, getting those is just really also just inspiring to me to get back in the lab and like really push forward on what we're doing here.
Well, it's great to have the large organizations recognizing the importance and significance of a reduced level of cognition for people and the impact on quality of life. So tell us about how cognition is often negatively impacted by epilepsy. Because I can say personally, memory issues are a huge thing. I mean, part of the reason, yes, I've had temporal lobe resection, but also, medications, potential seizures, it's the whole thing. How does it really work? And do you have any statistics on that?
How is it intertwined, or how do patients experience it in general? So memory is one of the most commonly reported problems in epilepsy, but when you look from study to study, the numbers reported kind of vary. And so, a lot of it's survey based, but if you do more formal neuropsychological testing, you can pick up on a lot more cognitive deficits, especially specific cognitive deficits, more distinctly and more quantified. But, for example, we had a study that we put out last year just on this symptom that patients will very frequently describe, which is just word finding difficulty. And this study was in patients with what we call drug-resistant seizures, or they tried multiple medicines already. But we had 79% of those patients reported word-finding difficulty. So it's a pretty prominent problem. Some of the more recent research can cite in general memory as a memory impairment in general. We can see in up to half of patients with epilepsy. People also report problems with attention, problems with just sort of we call executive function, so switching from one task to another. Those can be really difficult. But I will definitely say that memory in some form memory impairment in some form is probably the most common thing that I hear from patients. And it's not really surprising given what epilepsy is and where it is in the brain and how it affects things. One of the most common areas in the brain to generate seizures, or at least to be the seizure onset zone, is the hippocampus, my favorite.
Can't say it's mine, but yeah, sure.
But that's a super important structure for epilepsy. It's also very old machinery in our brain. It does this incredible thing where, it takes us back in time to whenever we want to remember something that happened before, or helps us pull out facts information. So, if epilepsy is affecting the circuits there, they're exquisitely sensitive to go awry, to have issues.
I guess, so you're talking generally about people with temporal lobe epilepsy then, if we're talking about the hippocampus, and are you talking about like people who might be having focal seizures or generalized seizures, or both? Do you have a focus there?
So if the focus of the seizures is in the temporal lobe, you would expect temporal lobe dysfunction, but you can have an epilepsy focus kind of practically anywhere in the brain. So the frontal lobe is very important for that sort of executive function I talked about before, where people would switch from one thing to another, or other sort of really high-level cognitive tasks that humans are really good at, right? But if you have epilepsy there and it's disrupting certain sections or certain circuits there, it's going to slow your ability to process information. Some people may even have their epilepsy area overlapping with language areas. So language area is important for understanding what people are saying, or for producing what they want to say for speech. And so that can weigh into the word finding difficulty reported for patients a lot as well. But there's a lot of different things, as you could imagine, that could cause the symptom of trouble finding a word. Again, memory, trouble producing the word. So it can be a really mixed picture from person to person.
And does your research show that this is largely or partially because of some sclerosis, for example, or brain damage itself, or is there a genetic factor, or could it largely be down to the anti-seizure medications, or sleep issues, or stress all interacting? Do you know?
It's still a huge area of ongoing research, right? But I can tell you, I know a lot of different main causes of it, and so I like to think of it in sort of compartmentalized way. You mentioned really important influences, which are medications. They can definitely slow down cognition depending on the medicine. Certain are worse than others. And then sleep loss, stress, these are things that can affect anybody with memory problems, but particularly people that are prone to memory problems, those factors will amplify their memory impairments. So that's sort of the epilepsy adjacent or related factors, right? And then we have the factors directly related to epilepsy. And I like to put these in groups in terms, because they're so broad, right? They can be broad. I like to group them by, we call static or sort of permanent impairments or changes that cause impairments. And that's really related to what I mentioned like before, the circuit changes, or really the etiology of the epilepsy or the cause. So primary generalized epilepsy, like you mentioned, that can sometimes be due to, we call channelopathies, problems with certain ion channels, and that's affected like all over the brain. So you could anticipate that they have multiple domains of cognition affected. But hippocampal sclerosis is a great example of, or it's one of the most common things that we see, where the circuits inside the hippocampus and other areas, the inner part of the temporal lobe, they are rearranged. And sometimes it's not just the rearrangement, it can be just hyperconnection. So cells or neurons connected to each other a bit too much, causing more excitability. You can also have the loss of certain types of cells, including these things called like inhibitory interneurons, things that are supposed to tone down the excessive activity. So if you have less restraint because you're losing more of those neurons. You make the network more excitable, and that can lead to seizures, but it can also lead to dysfunction in those same areas.
And some of that dysfunction can't necessarily, excuse me if this is wrong, but can't necessarily be sorted with seizure control. Depends upon the level of damage maybe that there already is.
Exactly. And that's why we refer to it. Sometimes it's like we say permanent. It's a very, it's a deep word to use, and I hate to use it, but at the same time, those are circuit changes that are, we can't just go in and rewire every single circuit, so those are changes that are probably lasting. It may be due to injury in that same area. So traumatic brain injury or other strokes, things like this can cause long-term damage in these areas that can lead to seizures over time. But again, this is referring to static or etiology-based or cause-based changes that are relatively permanent. It's different, though, than the effect of seizures and what we call interictal discharges. So I put these in a different domain called like temporary or transient impairments. And I think of them on a scale of time, right? So if you have a seizure, like especially a long seizure, things like status epilepticus, for example, very, very long seizure, then you're going to obviously have cognitive problems that entire time. That's, of course.
Yeah.
Or even, and depending on the type of seizure, of course, but if it's just if it's a focal seizure, that's still a big deal depending on which networks it's affecting. It can knock out someone's memory, their ability to lay down new memories for a long period. But it may be on the order of like an hour or like 5 minutes, and then they're kind of back around and up functioning again. And then all the way to the other end of the spectrum are these transient cognitive impairments due to just discharges in the brain. So a seizure is, repetitive discharges that continue for minutes, but seconds or minutes. But these are just discharges that usually happen maybe for a couple hundred milliseconds before they're gone, or really like the short part of it is like less than 100 milliseconds. Sometimes they can be repetitive bursts, but they may just last 1 or 2 seconds.
What are they doing faffing about just having like a millisecond activity rather than a whole, rather than a more significant seizure? And also, do these just happen in people who have regular epileptic seizures?
So we don't really hear about spikes much, too much. Yeah. So, when you put an EEG on in, let's say, 100 people with epilepsy, with known epilepsy, put an EEG on. Even if they don't have a seizure during the EEG, you can often tell that they have epilepsy because they will have these little discharges, these little waveforms that are quick and blips of activity. Those are usually coming from the area that wants to generate a seizure if it can, an excitable area, the seizure onset.
It's like it's trying, sort of in between.
Yeah, it's just like a little spark of activity, but it doesn't continue and go on to a seizure, right? If someone was to be on less medicines, then you might see a lot more of those, and you might see them eventually kind of transition to a seizure because they're just sort of sparking, and then it goes. But often they're just like occasional, maybe somebody will have one once a minute or something, or so. Sometimes people have them like every couple of seconds, though. I have patients where, on their RNS, so intracranial monitoring, they're out walking around. You can actually see they're having spikes every couple of seconds in certain areas. So it really ranges, right? But in those moments when this little sort of spike or spark is occurring, it's an abnormal burst of electrical activity, right? It's really short, but it's going to just pull a bunch of neurons really locally into that activity. And even if they're not that close by, they might still be affected by this electrical wave that happens in that local area. But then it's gone, So you've kind of briefly scrambled the activity in that local area. And because it's very local, it doesn't like spread, right? You're only going to see it really if you test for a function that's important for that area. So I was referring to the hippocampus before. If you have someone do a memory test and, ask them to recall things.
Or could they get confused as well, maybe, or say the wrong thing? Absolutely.
So it really, again, depends on where the spike is occurring. But if it happens in the language cortex, like the language area is important for production, they might have trouble producing it. If it happens in the area that's important for understanding language, they might literally not be able to understand what the person is saying to them at that moment. Whereas like a second later, they can. And again, this isn't usually a big deal to the point where we clinicians are trying to, adjust medicines to chase every single spike that happens. But for some patients with a lot of spikes, it can accumulate and it can add a lot potentially to the more permanent or static deficits that we see.
And I imagine, especially like, say it happens to someone when you're at school or college or university, it would make things extra difficult, right? Like, and you have to work twice as hard to actually try and remember things for your exam or whatever, however you're going to be assessed. Do you hear that from people?
Yeah, we may hear about absence seizures, right? And many of us know about those. Those are longer, though. Those are seizures, right? They're usually, we think of them in the order of 10 seconds at least to be considered a seizure. But sometimes, even if they're like 5 seconds, you'll still see the person sort of pause, right? And we put these labels on things and call those like absence seizures, and then spikes we just refer to as spikes. But we could have anywhere in between where they're lasting a couple of seconds and disrupting that function locally. So it really comes down to what the patient tells us. If they have perfect seizure control and they are having terrible cognitive impairments, and we look at their EEG and they're having a lot of spikes like all the time, that's a case where I would be like, I don't know, should we maybe adjust the medicines? Even though they're not having seizures, would it help? And it's basically just, there's no guidelines on that sort of approach right now. It's really just hearing the patients and hearing what they say, what they describe. And if we do end up adjusting medicines, it's very careful adjustments to be sure that we're treating what we hope to treat instead of just, again, chasing spikes.
Thank you so much to Jon, who in part 1 of 2 has provided us with a fab insight into the significance of the cognitive challenges so commonly faced by people with an epilepsy. Please do make sure that you join us next week in episode 2 of 2 with Jon, where we talk further about epilepsy surgeries, neuroplasticity, or lack thereof, and memory. Check out more about Jon and his work on the website torierobinson.com, where you can also access the podcast, the video, the transcription of this episode. And if you haven't already, don't forget to like, comment and subscribe to the channel, and share this episode with your friends, colleagues or family members. And see you next week.